Okay, so we had our case study on multiple sclerosis. I'm just gonna figure a point of view. So we all know what MS is, but I'll give you a quick rundown. It's unpredictable and oftentimes disabling. It affects the central nervous system, basically disrupting the flow of information within the brain and from the brain to the body. And it's the immune system attacking the myelin as well as the nerves themselves. Obviously the myelin around the nerves and so on. But the damaged myelin forms scar tissue, sclerosis, which is where it gets its name. And this slide, it's pretty self-explanatory, but it's a healthy brain versus you can start to see the lesions and plaques that are forming in the person who has MS. So 4 different types, which I'm sure we all vaguely recall, but I'll give you a rundown. I like the little arrows, they're really helpful. So the first and most common is relapsing remitting MS, and this affects about 85% of the people who are afflicted with this disease. Basically, Vanna White, everyone, that's nice. So, but it's periods of, like, you'll have exacerbations, and then you'll either go into partial or complete remission, and then, you know, another exacerbation, and then more remission, and so on for the duration. The next one is primary progressive, and this is much more rare. It's only affecting about 10% of the people who have it. And that's just a worsening neurological function from the onset of symptoms. So like as soon as you're diagnosed, you're getting worse and worse without relapses or remissions. The third one is secondary progressive, and this is you'll usually be diagnosed with relapsing remitting MS, and then that will turn into secondary progressive. It's kind of like the transition, and that's showing you, so you'll have the exacerbations and then remissions, and then eventually you just start getting steadily worse. So, and that's, yeah, there's no percentage on that, but that's quite common for those who are diagnosed with relapsing remitting. And then the final one is very, very rare. It only affects about 5% of the people, and that's progressive relapsing, and that's the worst of the worst. So it's steadily worsening, and then you'll have acute relapses, and then you'll worsen some more, and then acute relapses, and so on. So yeah, that's not a good one to have. So we did our case study. Her name is Kimmy Toostrong, which is fun. So she was an interesting case. She has relapsing remitting, which is the most common form of MS. Standard contraindications for people with MS is the strenuous exercise, which we all know, and the use of heat modalities, because you don't want to start an exacerbation. She does have some comorbidities, depression and substance abuse. The cause of the disorder, which is also not really known, is they classify it as a chronic autoimmune, but a lot of research is still being done as to how specifically it happens. Kimmy she's fairly strong, but she does have some balance issues, vestibular issues with the environment. She has increased tone in both lower extremities, but normal tone in her upper extremities. And as far as her MMTs, 3+ all around. So she does, she can move against gravity, but there is weakness, and there's definitely room for her to strengthen. Probably one of the bigger things is the generalized weakness and the endurance. She doesn't have a lot of endurance. And her postural balance, she's good within her normal basis support, but as soon as you take her out of that, she starts to falter. And as far as mobility, she's using a straight cane right now. She can ambulate about 200 feet, but then at that point she gets really fatigued and has muscle weakness. And then for the plan of care, there are so many different ways you could take the plan of care for people with MS. For her specifically, I really wanted to focus on yoga is a really great one for balance, because she does have balance issues, postural issues. And the other thing is we want to get that stability back. So the things that we've learned about in Harig, such as the rhythmic stabilizations, the alternating isos. Agonist reversals are a really good one just for transitional movements in the sit to stands, which are obviously demonstrated there. And then since she does have flexor tone in her legs, we have inhibitory techniques, prolonged stretches, so like the hamstring stretch where you can use the gait bell when you're laying down. So I didn't list out like the sets and reps because I thought that was more appropriate for the paper. But for here, we did marches and calf raises, which are really useful just for trying to regain some strength back in her legs. because one of her goals, short-term and long-term, is to be able to ambulate further, do more, have more endurance. And the other one is yoga is just such a immeasurably useful tool. What did I write here? So, I mean, it improves posture, flexibility. I mean, it's helpful for your cardiovascular system. I chose down dog just because it's a good stretch. It's a good way to like break up some tone and stuff, especially because she has flexor tone. And then warrior 2, if anyone has ever tried to do the warrior poses, like they're much harder than you would anticipate. Nice, yeah. So, and that is definitely developing more strength in her legs, being able, getting outside of that base of support, really working on the stability and posture and stuff. Yeah.
All right, so for equipment, there's a lot of different types of equipment that are used for patients with MS, and it just relates to ambulation, so them walking around actually, and then the re-education, and then transferring the patient. So I'm going to go a little bit more into ambulation.
Finger guns.
Okay, so we have orthotics, canes, crutches, walkers, scooters, wheelchairs, and Lima straps. So the orthotics, basically that's just going to be for the stabilization if they have even foot drop or just lower limb weakness. It's going to be used for that type of patient for MS. The canes, we use the straight cane obviously for Kimmy, too strong. It seemed to work out great for her. She did very well. And those are just basically used for that extra balance stability that you may need the patient. And crutches are very similar to the cane, but it's just going to be obviously bilaterally on both sides, and they're going to go through their hands again. So that's just going to be more stability again. The walker is going to be more for a patient who needs to possibly even sit down, because they have the seated walkers and the 2-wheel walkers, 4-wheel walkers, obviously, as we all know. And it's going to be more stability than just the cane, because the cane can obviously be more wobbly. So it's going to be for a patient who might need that extra support. The scooter is going to be also kind of like a walker, really. They have a 3-wheel one and then a 4-wheeled one. It's going to be kind of a mobilization device where they can get around like in stores and all that. You see that a lot. Wheelchairs, they have many different wheelchairs out there, obviously, but just depending on the level of MS that they have, depends on what level they're going to need for a wheelchair. They're going to need the manual one, a power one, whatever they're going to need. And then a Lima strap, I put that on there. I didn't find it in a study at all, but I've been seeing this in my clinicals. And they actually, it's this right here, what they have, and they put it around the waist, and it helps with hip movement and rotation. And then also brings up that foot into dorsiflexion when they're unable to. So it keeps them from doing like foot drag or toe drag and like foot drop. Keeps them from doing all of that. So it's really helpful. So then they have the re-education. So this is the functional electrical stimulation, which we've been kind of touching on in class a little bit, where it just contracts that muscle and puts them into that dorsiflexion. So when they're unable to do that the walk like what we normally do, putting their foot into dorsiflexion. So it helps do that. And then this is really good for MS patients who have that function still. They're able to move and everything, but they're not able to get that correct mobility and the correct motion down. So it's really good for those type of patients who still can walk and still can get up and move around. It's good to see them using it. It improves balance deficits, risks of falling, and all of that too. So transfers, this is mostly seen in like nursing homes or long care facilities. They have the Hoyer lift system and then the track lift system. So it's going to be more for patients who, the MS patient who is going to be obese or just unable to get up and move. It's good for transferring them to the wheelchair or to a toilet even at that case. They also use this for a lot of other diseases and diagnoses out there, but this is just one that I've seen even in the clinic. I've had to help patients get into this to be able to get up and just actually pressure relief, it helps with that so they can get into different positions. So it's really nice for that. These are some symptoms. They're just the primary symptoms of MS, and then they develop into secondary symptoms, and then they often have tertiary symptoms as well. With these primary symptoms, you want to try to correct the primary symptom before it turns into a secondary symptom obviously. But like with the bladder dysfunction here, this one can also turn into like UTIs and stuff, obviously, so you want to kind of watch for that. You want to try to correct it before it turns into UTI. You can obviously correct the UTI, but it's more beneficial for the patient if you correct it before. Inactivity, you lose muscle tone, obviously. And then I saw another one that was interesting. They have difficulty sometimes chewing and swallowing, and that can lead to aspiration pneumonia, which can be very fatal. It inflames they have inflammation and fluid and accumulation in the lungs, so it can be just very fatal, obviously, for the patient. Some of the tertiary symptoms were like social or vocational, psychological complications, and it's for patients who might have difficulties driving or walking and like going to work, so they can't have an like ordinary life, you know. So things start to get very difficult. Some become very depressed, and they just become very isolated in their area, so they're not able to do a whole lot. So that can just be a tertiary symptom. It's very progresses fastly for that. And then you can go to the next slide. So these are the desired outcomes of prognoses. You obviously have the good side of the prognosis and the poor side. It tends to be more common in females than males, but if it happens in a female, the chances of the prognosis is a lot better than a male. So that's something that we have a benefit of. Sorry, Nate. And then the younger you are also is going to be better. They also said that, well, there is no cure, obviously, to this date for MS, but 1/3 of people with MS lose the ability to actually walk, whereas the other 2/3 have the ability to walk or use an assisted device, so that's very helpful and just nice to know that they can still get around. So the best prognosis basically is anyone who is female, young, they have infrequent attacks, relapsing, remitting, obviously, like Miranda said, is the best to have if you're going to have it. And then just a few signs of the disease, so if they don't have a lot of the symptoms that I talked about earlier and showed a bunch of them there. It's rarely fatal though, so most people they live as long as probably a month or 2 months less than the average person, so they still live the full life expectancy generally of what you would expect. So these are just more, I'm going to read them.
The end.
Will you introduce yourself to Maria? Is that about that?
Oh, hey, I'm Miranda Homrich,
I'm Kristine Harig.
and we did MS. Now the end.